Right, progress so far. We're now in our third year, this is the beginning of a third year, and we are starting to get traction on our moves. We achieved a 500k surplus in 14-15, that means we had that in our pocket to put into this year. So what we've done is that money has gone into the transformational fund for this year, and that will help us with training, education, support, project managers, different bits and pieces that we need to actually get to where we want to go. And it allows us then to actually upskill people as well, including GPs. We've made progress on developing the Alliance workforce and OD plan. We've done quite a bit of work on the OD and about the workforce. The workforce was a very flat structure, and we've actually taken that and tried to develop a structure so actually there's career progression, also looking at new roles, what we can do differently, what training our staff need, and that also includes upskilling in primary care and GP land and what actually we can help support in that area so that we've got the services that we need going forward. We've had positive patient feedback, and I think you'll see some of that in a little bit when we see the video. DVD it probably will be now. But and we're making good progress against our targets. So with regards to RTT, we're where we need to be. We're doing, from a cancelled ops perspective, we're not doing as good as we could do, and we have done some work on that. We've done a LIA project around actually improving pre-admission so that we reduce our cancellations. We're doing quite well on diagnostic waiting times. That's been an area that we did have problems with, and that's getting better. We still have some issues around colonoscopy, but we're working closely with UHL on that. And that's one of the key things that is in the past, whereas it would have been a bit more of an adversarial relationship, we are actually working in partnership, so that's a real plus. We've now, our percentage of appraisal for staff, that's now gone up to in the 90s, so we've made some progress there. So what have we actually done? And this is what, there's loads of people who say to me, so what have you done for me? And we have been, for this year, we've got an agreement for 6,000 dermatology appointments to move from UHL to the Alliance, and that's not just county-wide, it's city included. 500 cystoscopies from UHL to the Alliance, and that is county-wide. 750 ophthalmology photography appointments from UHL to the Alliance at Melton and then Loughborough. Gastro, we've got 2,300 gastroenterology appointments that are moved, and we've got another business case to make that forward, and that includes endoscopy. And actually we started to, we've got a YAG laser that we've got in Melton, and that's already started to look at its move 40 YAG laser appointments, and that will be an expanding profile going forward. So a lot of people have said, so I'm in Hinckley, so what have you actually done for me? So we have actually started to look and say, so what have we done in, so if we take Hinckley, additional sessions there to support left shift commencing in July, so they're ready for action to set for there. We've also moved ocular plastics, they commenced in April 15, so we've been doing a lot more ocular plastics outside in Hinckley. We've been running a specialist glaucoma service there since September 15, and we're going to do the YAG laser there from the autumn. So then Loughborough, nurse-led clinics from autumn 16 in dermatology, that's going to be a new sort of initiative. Gastro, additional sessions to support the endoscopy shift, and that we've done from July because that's when the new appointments for gastroenterologists are commencing. And then optometrists deliver glaucoma clinics to commence late in autumn. So it's about changing the way we deliver a number of our ophthalmology services, and we've done a lot of work with the optoms on this. For Melton, ocular plastics commenced in April, YAG laser October this year, specialist glaucoma services started, And actually for paediatric ophthalmology, we're developing a combined care from, we've done it from January of this year, because the paediatric ophthalmology service is long in need of an overhaul. Oakham, nurse specialist has commenced in dermatology and started to run a nurse-led service from April of this year. Then we're also looking at running the specialist glaucoma service from May 15 there. St Luke's, that's where we will be starting to also look at some further gastroenterology once we get, there's 3 currently gastroenterologists in the pipeline. 1 starts in July, 2 start in September, and then there's a business case going for a further 3, and we probably will add a 4th into that. And so the goal is to get all of our endoscopy suites filled up, and then actually that helps UHL sort out some of the issues with demand management across the board. They've again, so if that sort of leads you on to further things, more oculoplastics. We're looking at ENT day cases starting from in Melton from autumn 16. That was never on the cards before, but it is now, which is really, really good, and it shows how, you know, joint working starting to work. We're doing very much more around the cystoscopy part, and also about moving more of those out in the second phase. So that gives you a flavour for what's happening in localities, and I know the GPs have asked me that, so what have you done for me? And the patients want to know what's happening in their local area. We've done a lot of work as well around looking at our own staff and how do we develop our staff going forward. And we ran an outpatient nurses event actually in March of this year at Loughborough that went down really well with the staff, and we're going to roll that out across the board to all the other areas, including day case. The paediatric surgery waiting list management review across Melton, Hinckley and Loughborough, it's approved waiting times, because of course that's not on an 18-week pathway. So what we've done there is actually mimic an 18-week pathway, but to actually make sure that patients aren't waiting unduly and there's no disparity between sites. The day case team at Hinckley, as I said, have already done a load of work on improving the pre-op process, pre-assessment process, which will roll out. Strengthen leadership through improved local structures at the community hospitals, because we did need to do that. So actually there's some site leadership, because that was one of the things that our staff told us, was they didn't feel that there was a lot of site leadership. And the PPG have undertaken a number of place visits looking at the facilities, signage, also patient experience. They've done Melton, Loughborough and Hinckley, and the findings that will be enacted upon to improve services. The future. We're looking at, we've looked at 8 specialties so far for moving out. We've got to do the further work for the other 10 specialties to move out into from an alliance perspective. We've got to look at, because the alliance is made up of what we call 3 pillar contracts. I always describe it as a Parthenon, and most of the activity is currently in the UHL pillar, and we've got to start to develop the LLR PCL, which is the GP practice pillar, and get more activity out into the practices, so that actually we can use the absolutely brilliant facilities that are available within primary care, and also get the LPT pillar contract. We need to do that with the paediatrics and probably physiotherapy, and maybe even medical day case going forward. Increased training and development for staff, that's key. Development of new roles, and we're working on the nurse endoscopies, ESPs, various other areas that we're delving into, and also what do we need to support our primary care colleagues in training out in actual primary care, including the GPs. And we're doing a whole diagnostic provision review based on the fact that at the moment we've not got a lot of diagnostic hubs, and there is a feeling that that's what we need. Patients need to be able to, if they're getting an outpatient appointment, they need the relevant diagnostics where that's happening. And also not everybody wants to trundle into UHL. Their footfall is massive with diagnostics, and also they've got pressure on their waiting times. So we need to be able to work as an LLR economy to do that, and that's not just about plan care. That's how we work together with the urgent care, long-term conditions as well. One of the other things that we're doing is looking at reaching out. So, and there was lots of conversations we've had at the Alliance Leadership Board that a lot of patients don't know what the Alliance is, who we are, and that can be said of staff as well. So we're doing some listening booths. That's the initiative that we're going to start looking at, reaching out to patients across LLR. We've developed a new website, and there we are. That is our new website name for you to actually look for. And we've actually now got our own Facebook and Twitter page. So what more could we ask for? What next? Further improvements to services. The key things is we've got to move at pace, because we're in the third year. This is a 3+2+2 contract, so we've got to show that we're of benefit to the health economy. We know we've got a huge financial gap across LLR, and actually we're part of the solution there. And the other thing that we've got to do is we've got to show that we can actually work together, and that's part and parcel of, Paul said that earlier, of this event is actually what do we need to do together, because we can't do it alone, so we need to take that forward. We need to do a lot more around connecting the system, and that's a lot of IT is involved in that, and there is a work stream for Better Care Together. We're linking for that, but that is a key thing and a major frustration currently. And we need to do more for less and better, because actually we need to improve the quality of the patient care, but we haven't got the funds, so we've got to do what we can do for cheaper where possible. That means you can't do cardiac surgery cheaper because the kitchen table wouldn't work. But you know, in areas where we can make provision and improvements, we should do. The Alliance is paid for the activity it undertakes. The more we do, the more income we generate, the more investment we can make back into the NHS across the Alliance. Because the surplus, the whole thing is the surplus goes back into the system, and it will also, it's there to help. So when we do the business cases, if UHL, for instance, couldn't actually release all of its cost in a timely fashion, the thing for the alliances is that we can actually help bridge that gap, so that actually you're not asking the impossible of the acute trust to lose a whole load of income without losing, you know, the fixed cost and the semi-fixed costs. So that's one of our major benefits. And really, that's an introduction and a whistle-stop tour through where we are and what we've done to date.